then because our target audience is usually physicians, medical officers, and probably those at the clinic kesihatan. So this is sort of like a short sort of teaching session, because not everyone can come for those conferences which is held most of the time in KL. So yeah, this is sort of an effort to let everybody get input from all the experts in their respective fields. Yeah.
Yeah, okay, no, just wanted to clarify. So this month is Infectious Disease Month. Okay, right.
Yeah, and this is the final week of that month.
Okay, right. And when Carol goes on, do you want in terms of cameras,
usually, yeah, only Dr. Kyril's camera will be on at that point, so we can actually off our videos at that point, and then when the question starts, then we can on. But when we go live shortly, I would appreciate it if we can all turn on the cameras. That'd be great.
Yeah, no problem.
Okay. Thank you. Thank you.
Do we get to see your face before that?
Yeah, sure.
I know Vidya.
You know her?
Was the MO in HKL before she left to Taiping.
I see, okay.
It's nice to reconnect with familiar face.
And we've got a number of note takers here, is that right?
Yep. I think we've already got 20, 30 participants.
Is there a max for this Zoom session, Vidya?
Sorry, Dr. Karen?
Is there a maximum number of participants for this?
Oh, no, I don't think so.
I'm going to be on this Zoom thing now. Just maybe I can close the door. Is that okay?
I didn't know that you were in Taiping. I know you're in Perak, but I wasn't.
With Dr. Avinash as well.
Okay.
Yeah.
Avinash is infectious diseases now, is she?
Avinash is acute internal medicine.
No, she's in right. Okay, internal medicine and
acute internal medicine, AIM.
Okay, right. In Taiping, right?
Yeah.
Okay. And Kyril is the syphilis man, forever and ever. He's given some talks on syphilis.
I heard there's a candlelight something going on tonight, Prof. Made candlelight dinner evening with you.
I know. It's please make sure you don't come. It's so ridiculous. I don't even know why they created that. And everybody's been taking the piss out of it, okay? Piss out of me, thinking that I'm going to be eating and have a romantic candle there. And then what else? And then being live streamed. Oh my God, it's so
it's good, it's catchy, it's sort of like.
That's right. It is catchy. Yes, it is catchy. I had nothing to do with it. Okay. Nothing, completely innocent.
Okay, wait, let me just check.
Dr. Vidya is welcome. If you want to have a romantic candlelight dinner with me tonight on Zoom at 8:30, you're more than welcome to join.
Okay, I think we can start. It's 3 now.
Yep.
Yeah. Okay. Hi. So a very good evening to everyone in attendance. Welcome to the final week of the Infectious Disease Month, and the topic for today is sexually transmitted diseases, in particular syphilis. So our speaker for today is Dr. Khairil Erwan bin Khalid. He is a senior consultant physician and infectious disease consultant in Hospital Kuala Lumpur. And our chairperson for today is Professor Dr. Raja Iskandar Shah Raja Azwa, who is currently practicing in University Malaya Medical Center. So before I start, I'll briefly introduce Prof. Raja. Prof. Raja obtained his medical degree from the University of Dundee, Scotland, and subsequently obtained his MRCP UK in 2003. He then went on to complete his complete his ID training in UK and obtain his certificate of completion of training, CCT, in the UK in 2009. Prof. Raja also has a diploma in HIV and genitourinary medicine. Besides that, he also holds many positions, including the president of the Malaysian AIDS Council. He's also the associate prof and clinical lead HIV services and ID unit in UMMC, and the head of Center of Excellence for Research in Infectious Disease, UM. Apart from that, Prof. Raja is also actively involved in numerous research centered around HIV and PrEP. And he's also has been chosen to be moderators for various national and international gatherings. So without further ado, Prof. Raja, the floor is yours.
Thank you very much. I don't really think I deserve that introduction because the focus really should be on the speaker, which is Dr. Khairil. And I know Dr. Khairil doesn't want me to go through CV at length, but all I can say is that Dr. Khairil is a colleague, a senior consultant in infectious diseases in University in Hospital Kuala Lumpur, and is also the head of Infection Control Unit. I've known Khairil for some time. He's also done quite a lot of genitourinary medicine work in London and was very well respected by colleagues in London when he did that. And since then has really been speaking on a multitude of STI-related topics, of which syphilis is just one of them. But I think the last three presentations of syphilis that I've heard have all been given by Dr. Khairil. And so if you miss out his syphilis talk, there's always opportunities to hear about monkeypox as well. So Dr. Khairil, the floor is yours.
Thank you, Prof, for the kind introduction. Okay, let me share my slides. Right. Okay. So firstly, thanks to the College of Physicians of Malaysia for inviting me to speak today on one of the common sexually transmitted infections that we encounter on our day-to-day practice, which is syphilis. So I'm going to start off with a case. First case, we have Mr. S, who is a 34-year-old MSM who actually went to Clinic Kesihatan Kuala Lumpur in 2020. He initially presented with painless ulcer over the penile shaft about a month after unprotected insertive sexual intercourse with another man. So on examination, it's got a tender left inguinal lymphadenopathy and an ulcer at the penile shaft. If you can actually appreciate the ulcer on the picture here, there are a few sort of shallow ulcer on the shaft. And his HIV antigen, antibody, and PA turns out to be positive. So he's newly diagnosed HIV at the same time. The syphilis serology, which was sent at that time, the RPR, and it came back non-reactive. There was no other evidence of opportunistic infection at that point of time, and because of the presence of the shallow ulcers here and the RPR being non-reactive, he was treated for herpes and was given an acyclovir, and unfortunately, he defaulted follow-up after that. All right. And if you actually have seen, or I hope that all of you are aware of our recent launched Malaysian guidelines on the management of STI, 5th edition, which was just launched in July this year. If you look into the modified syndromic approach chapter, if you go through this algorithm, when someone who comes to your clinic with a genital ulcer, there are sort of 4 differential diagnoses that you could actually consider based on whether the ulcer is single or multiple, whether it's been painless or painful. So generally, someone who comes with a painless ulcer, like our patient here, you could think about things like primary syphilis or chancre or LGV. Traditionally, genital herpes and chancroid, the ulcers tend to be painful. Yeah. Anyway, a year later, in April 2021, he revisited Clinic Kesihatan Kuala Lumpur, but at this time, he actually came with generalized cutaneous rash, fever, and diffuse lymphadenopathy about 3 days. So on examination, there was generalized maculopapular rash, also involving both palms and soles, as you can see in the picture here. And the RPR was sent and it was still non-reactive, but because of clinically it looks like secondary syphilis, the FMS called the lab in HKL and asked to proceed with TPPA, and it turns out to be detected. He was then referred to us for further management. So basically, when we saw him in HKL, because of clinical picture of secondary syphilis, but the RPR remains non-reactive, we actually called up the lab and asked them to sort of further dilute the RPR. And then true enough that the dilution came back as 1 in 128. So diagnosis of secondary syphilis with Prozon phenomenon was given. And then he was given 1 step dose of iron benzathine penicillin at that time, right? So syphilis is basically an infectious disease caused by Treponema pallidum, right? It can be transmitted through sexual contact with infectious lesions of the mucous membranes or abraded skin, okay, which is the most common route of transmission. It can also be transmitted by blood transfusion and also transplacental from a pregnant woman to her baby, okay? When we talk about syphilis or in managing syphilis, it's always a good practice to sort of define the stage or to classify the syphilis, whether it's being in the early part or the late syphilis, okay? So generally we tend to, I mean, we in adults, we only see acquired syphilis case. So we can actually divide it into early and late, depending on the duration of the acquisition of syphilis. So if you acquire syphilis within 2 years or less than 2 years, generally we are talking about primary syphilis, secondary syphilis, or early latent syphilis. Whereas if somebody who has acquired syphilis beyond 2 years, then it can be either late latent syphilis, tertiary or gummated syphilis, cardiosyphilis, and neurosyphilis. But bear in mind, neurosyphilis can also happen early, particularly in secondary syphilis. So it is important to know whether we are dealing with early syphilis and late syphilis, because early syphilis tends to be more infectious compared to late syphilis, and it also matters in terms of treatment. Yeah. So syphilis is a systemic sexually transmitted infection, unlike other STI, for example, herpes, which tends to be sort of localized, or gonorrhea or chlamydia, for example. So syphilis can affect any parts of the body. So it's a systemic STI. As I mentioned earlier, infection is transmitted mainly via sexual contact with person in the early disease, because in late disease tends to be less infectious. Incubation period from somebody who has acquired syphilis in developing primary syphilis can go up to about 90 days. And signs and symptoms are only seen in early and late disease. Yeah. They tend to be asymptomatic in the latent disease. Okay, so primary syphilis, it is classically described as what we call solitary, painless, indurated, and well-circumscribed ulcer, or also known as chancre. Okay, it is commonly located in the anogenital region. However, chancres can be atypical, meaning that they can be multiple, it can be painful, it could be purulent, and can also affect extragenital sites, most frequently in oral cavity, especially in HIV infected patients. Okay, it usually lasts about 1 to 6 weeks, and then it will resolve. So it has spontaneous healing, and it may be associated with regional painless lymph node. Because of the nature of the painless ulcer, some patients, or I would say majority of patients who actually have chancre, they are not aware that they actually have primary syphilis because there's no pain. And then usually without any treatment, the chancre will actually go away by itself, right? So if it's untreated, then it will progress to the next stage, which is secondary syphilis. So here are just some examples of pictures to show all of you how a chancre looked like, all right? Okay, then moving on to secondary syphilis. So secondary syphilis would have a longer incubation period. It can be as early as 6 weeks and up to 6 months. In secondary syphilis, it's basically, I would say, the bacteremic stage or bacteremic phase of the syphilis, because in secondary syphilis, there is dissemination of organism that results in systemic manifestations. Okay, because of the systemic dissemination, so patient would experience symptoms like low-grade fever, adenopathy, headache, and malaise, and they have certain manifestation or criteria that it's quite suggestive or I would say very highly likely associated with secondary syphilis. So classically, patient would have a generalized non-irritating skin lesion. It can be generalized, but most of the time it affects both the palms and the soles, typically maculopapular rash. They can come with condyloma lata, which I'll show you some pictures later. They can get patchy alopecia. They can get mucus patches and some snail tract ulcers. And in about 30% of patients who actually come to you for the first time with secondary syphilis, the primary chancre may still be present. Okay. So because of the nature of dissemination and the systemic manifestation of secondary syphilis, the patients may also have other target organ involvement, such as ocular involvement. So patient would probably have what we call ocular syphilis. So majority or most common part which is affected is actually your posterior uveitis, but they can also come with other parts of the eye with inflammation. They may have neurological involvement. They may have hepatitis, splenomegaly, and nephrotic syndrome. And as a general rule of thumb, all serological tests for syphilis are expected to be positive in secondary syphilis because it's a systemic bacteremic phase of the syphilis, and the titers in untreated cases are often more than 1 in 8. All right. So this is classic pictures of if you can actually see with somebody with secondary syphilis who comes in with rash. So it can be generalized rash, but typically we can actually see the rash on the palms and the soles. And then these are some examples of mucus patches. This is what condyloma lata looks like. So in clinical practice, sometimes it's difficult to sort of distinguish whether are we dealing with condyloma lata or are we dealing with condyloma acuminata, which is your anogenital warts, because you know anogenital warts are caused by HPV, as opposed to condyloma lata is because of secondary syphilis. So sometimes we may have to, you know, with somebody who comes in with these lesions with a positive syphilis serology, you will treat a secondary syphilis and you observe the lesions, and usually it will regress. If it doesn't, then you probably need to get some input from your dermatology colleague, and then you may need to have a biopsy sometimes. And then this is a picture of a moth-eaten alopecia, which is characteristic of secondary syphilis. So when we talk about diagnosing syphilis, we are basically relying a lot on laboratory testing or serology testing for syphilis, right? It's unlike other STI, let's say for genital warts or herpes, where it's mainly clinical diagnosis. But in syphilis, we rely a lot on blood tests, particularly the serology. So I've divided the laboratory test for syphilis to two, which is the first one is called the demonstration of the Treponema pallidum itself, either via direct visualization or molecular testing. So direct visualization is basically referring to your dark field microscopy, which I think I've not seen any labs or in MOH, for example, that actually do this dark field microscopy. So it's sort of become obsolete. And then, of course, if you're in a private setting or if you have the facility to do PCR or molecular testing, then that's another way to actually detect Treponema pallidum in the ulcer or in the skin lesions. But majority of us, I think, are still very familiar with the STS, or what we call the serological test for syphilis. So serology test for syphilis can be divided into NTT, means non-treponemal test, and TT, which is a treponemal test, which is specific treponemal test, which we use as a confirmatory testing. Apart from these two, we also have specific treponema pallidum antibody that detects the IgM or the total IgM and IgG via enzyme immunoassays, either CIA, EIA, CLIA. And then we also have what we call rapid diagnostic test, RDT, which is mainly used in clinic kesihatan, mainly in the antenatal follow-up. Yeah. So again, the NTT is actually the non-treponemal test. It basically measures the antilipid IgM, IgG produced in response to the lipoidal material released from the host cell of the cardiolipin of the T pallidum. So that's why it's not specific. So these are the tests that we are very familiar with. Either we use RPR or VDRL, right? Then you have the TT, which is the treponemal specific testing, where it detects the antibody against the T pallidum protein directly, which we use as a confirmation test. So we have TPHA and TPPA. We also have FTAA apps, which which hardly use because it's small labor intensive to use it. And then we have EIA and CIA and RDT. Okay, so RDT is, I think, whoever is working in clinic kesihatan, who's handling antenatal mothers would be familiar with this, because we use rapid diagnostic tests. Basically, it is specific treponemal specific testing. It's an antibody rapid test. It's a point of care test. So it is useful in the following situations: in high-risk mothers, in someone who comes in as a late booker who comes in at more than 28 weeks of period of amenorrhea, or if to be used in hard-to-reach population, as for example, for the Orang Asli or interior in Sabah Sarawak, where you know that patients may have lost to follow up or it's difficult to reach. So we want something point of care test to actually detect the syphilis and give the treatment on the same day. And of course, for clinic kesihatan ibu anak or KD with no lab facilities to do RPR VDRL. Okay. So we have this guideline talking about the elimination of maternal to child transmission of syphilis and HIV that was published by KKM. And here we actually define what are high-risk mothers. So basically, to use RDT syphilis, if the mother happens to be a sex worker who has history of HIV or STI in the past, history of multiple sexual partners with HIV and all this, yeah? So what is recommended in this guideline is that if the mother comes in booking and then the RPR or the RDT is negative, we should repeat the RDT at 28 to 32 weeks of gestation and again at delivery. So that's why we actually emphasize the use of RDT to get the results fast. But I think Ministry of Health is in the process of trying to make it compulsory, not just for high-risk mothers, but for all antenatal mothers who actually come in booking and the syphilis is negative, and to repeat at 28 to 32 weeks of gestation with the use of RDT. But it's still in the process because you know, there's a lot of things to take into account in terms of procurement and so on. All right, so now we look at syphilis testing performance. Again, if you look at the primary syphilis, you have the non-treponemal test here, the NTT, the RPR, VDRL. So you look at the sensitivity, it's not as great if you use a treponemal specific test like your CLIA, EIA, which your sensitivity is much higher to detect syphilis in the early part of the disease. So we'll talk about this later when I talk about traditional algorithm versus reverse screening algorithm. Okay. So generally, for a non-treponemal test like your RPR and VDRL, the advantage is simple, it is inexpensive, and it's rapid. But there are some disadvantages associated with NTT. It has got low sensitivity in early stage. due to window period, and as I've shown you earlier, that the sensitivity is much lower. In like our case, it can be affected by this prozone phenomenon, which I will explain later. And also because the nature of it being a non-specific treponema test, it is prone to be getting biological false positive. So especially in pregnant mothers, in someone with autoimmune disease, post-immunization or some viral infections, you may get a false positive RPR or VDRL. All right. Whereas if using treponemal specific testing like your TPPA, TPHA, the advantage is it complements the non-treponemal test in early syphilis if it's positive, but the disadvantage is that, as you know, like TPHA and TPPA, you cannot use it to evaluate the treatment efficacy because it doesn't give you a titer. So it's just written as detected or not detected. That's that. All right. A little bit on how we interpret the serology. Okay, I think all of you are aware that usually when we do the RPR or the VDRL, it will give you a titer. All right. So usually what we look is what we call a four-fold change that corresponds to a two dilution change. So just remember the number 4. So let's say if somebody who comes in for the first time with a titer of 1 in 8 and you have treated adequately and the patient does not have risk of reinfection. So we want to say a 4-fold reduction. So means that by 8, if 4-fold, it should come down to 1 in 2 or lower. So if you want to see whether the patient has been reinfected, let's say if he comes with 1 in 2, and then you have treated, but somehow he gets reinfected, and then when on follow-up, it gets 1 in 16 or 1 in 8, which is 4-fold, because 1 in 2, if it's 4-fold, means it's 1 in 8, right? So if there is 4-fold increase, then most likely the patient has been reinfected. So just remember the number 4, and then you times it or you divide it depending on the titer. And then the second box that I've made here is basically just to tell you that if somebody who has been treated for syphilis and then there is no risk of reinfection, on monitoring, if you see that the titer, let's say from 1 in 2 to begin with, and then it comes up to 1 in 4, means that there is only 2-fold change, right? From 1 in 2 to 1 in 4. But patient is clinically well, has been adequately treated, and there's no risk of reinfection. You don't have to do anything. Just continue to monitor because it is only 2-fold difference. But of course, if it's 4-fold and above, then you have to raise a suspicion of reinfection or reactivation that prompts a need for reevaluation and treatment. This is because when you read the RPR card, it is sort of operator dependent. So maybe person A would read it as 1 in 2, as or person B may read it as 1 in 4. So the difference we allow of 2-fold difference, but as long as patient clinically well, has been adequately treated and no risk of reinfection, you don't have to do anything, just continue to monitor. So this person does not have to be injected again. All right. So these are 4 possible serological scenarios when you have your RPR and TPPA results. Okay, let's go at first scenario, which is your RPR non-reactive and TPPA non-reactive. Okay, so it basically means that the patient has no syphilis, or the patient might have syphilis, but it's still in the incubation period. Hence, the RPR and TPPA is non-reactive. Or the patient would have primary syphilis, but it's still very early. As I've shown you just now, the RPR sensitivity is not that great in early primary syphilis, and TPPA is almost the same. The best is still by using your EIA testing. Okay, moving on to the second scenario, which is RPR non-reactive, but TPPA reactive. So it means that it could be very early primary syphilis because your TPPA will be positive first, or like in our patient, this patient has secondary syphilis with prozone phenomenon because the RPR is not reactive, but TPPA is reactive. Or this patient may have had syphilis in the past, it was not treated, but for some reasons, the RPR comes to non-reactivity, okay? Or the patient who has had syphilis in the past, it basically means that patient has been treated for syphilis in the past, okay? Then if you have scenario number 3, which is RPR is reactive, but TPPA is non-reactive, it basically means that it is false positive. Okay, if the patient does not have clinical suspicion for syphilis or have any high-risk behavior. So if the patient has the situation number 4, which is both RPR and TPP are reactive, so it's positive for syphilis diagnosis. But please bear in mind that other spirochete disease like Lyme disease or endemic non-sexually transmitted treponema disease like yours, Pinta, that sort of disease can also give rise to this RPR and TPP reactive. So sometimes we do see this, what we call endemic non-sexually transmitted treponema disease amongst the orang asli community in Perak or in Pahang. So sometimes when they do screening, it turns out to be both positive. It doesn't mean that they have an outbreak of syphilis, but it's because of this endemic non-sexually transmitted treponema disease. Okay, right. So what is Proson phenomenon, like what our patient has? So basically it means that it's a false negative response because of a high antibody titer that interferes with the formation of what we call this antigen antibody lattice in order to make the flocculation test to be positive. Okay, so what it simply means, okay, let me try and simplify it for you. Generally, when somebody who has a very high load of spirochete in their body, for example, in secondary syphilis, right? As I mentioned, it's a systemic bacteremic phase of syphilis. So you have very high spirochete load in your body. So obviously your antibody would also be very high in response to that. So you need this antibody to form a lattice or like a complex what we call the antigen antibody from the RPR reagent to be able so that to give a dilution until it becomes a positive flocculation to give that titer. But when the antibody titer is so high, it cannot form this lattice network. So the RPR card would not be able to pick it up and flocculate and give you a titer. So hence, that's why you have a false negative results. Okay. But of course, when you do a TPPA or a treponema specific testing, it will be detected because Proson is not affecting a specific treponema testing. All right. So Proson phenomenon in syphilis is most often associated in secondary syphilis, in neurosyphilis, in HIV infection, and also in pregnancy. So if you do see patient who has suspicious of high-risk behavior and clinically suspicious of syphilis, but the RPR is non-reactive, please consider Proson phenomenon, whether you just call the lab, whether they can actually proceed direct with a TPPA or a TPHA, or you can actually ask them to further dilute the RPR until they get a titer. Okay, right. Again, this is just to share with you, the Director General of Ministry of Health has actually come up with this screening algorithm. There was actually, this letter was dated on the 24th of August last year, talking about 3 different algorithms to be used mainly in clinic kesihatan or in the government health facilities, including universities as well. So the first algorithm is what we call the syphilis testing using traditional algorithm, which we are familiar and it has been done for many years before this. So basically what it means is that you do an RPR or a VDRL, but most of the time now we have not used VDRL, we use RPR. So RPR, if it's non-reactive, it stops there, right? If you follow this algorithm, like what happens to our patient. RPR non-reactive, it stops there. Only if the RPR is reactive, I mean, it gives you a titer, then they will proceed with TPPA to confirm your RPR to make sure that it's not false positive. Okay, so that's the traditional algorithm. Then there is a second algorithm here, which we call reverse algorithm, which most countries have actually moved to what we call reverse algorithm. Okay, so what it means is that we use a screening test by using a treponemal specific testing, right? Using the platform of EIA, whether CMIA or CLA, enzyme immunoassay testing. If it's non-reactive, it stops here. Okay. As you know, as I've shown you just now, the sensitivity using this EIA testing in primary syphilis is actually higher. Okay. So when it is reactive, then we do RPR to give you the titer. So that we decide whether to treat or not to treat. If the EIA is reactive, but RPR is non-reactive, then it is proposed to use the TPPA as a tiebreaker, okay? And then to see whether it's positive or negative. So in this algorithm, they actually come with a suggestion of laboratory interpretation as well, okay? So that is reverse algorithm, all right? Then we have a third algorithm, which is called the rapid diagnostic testing that has been used in clinic kesihatan. Generally, rapid diagnostic testing, RDT, also adopts the reverse screening algorithm because if you remember, RDT is also a treponemal specific testing, right? It detects the antibody. So it follows here. If it's negative, it stops here. If it's positive, we write in the guideline here, refer FMS or MO who actually sees the patient in the clinic, and then to decide whether to give treatment on the spot or send the RPR and wait for the RPR to come up with a titer. So here, if the RPR is non-reactive, but the RDT is positive because it happens sometimes, then you need another test as a tiebreaker. Either you can use your EIA or your TPPA to make sure that the RDT is not false positive. Okay, so these are the three algorithms that have been suggested to use. Ideally, we should all use reverse screening algorithm now because, as you know, there are some advantages associated with reverse screening algorithm, but we give the options to the healthcare facilities as well because not every hospitals or healthcare facilities have the capacity to do EIA testing because you need an analyzer to do that. So I've sort of summarized here what are the advantages and disadvantages of TSA, which is traditional screening algorithm, versus RSA, which is a reverse screening algorithm. So the traditional screening algorithm that we have been using before this is affordable and suitable for low volume lab and detect active infection. But the downside is that it's operator dependent. As I mentioned, when you want to read the RPR cut is operator dependent. It is prone to have a prozone effect. So you will not be able to eradicate this prozone effect issue because you're using a RPR, a non-treponemal test as a screening test first, and then you are prone to have biological false positive, and you may miss diagnosis of early syphilis because the RPR is not reactive yet. It's not reactive yet. So the reverse screening, basically the advantage is avoid false negative or prozone effect. It's useful in high volume screening. It's higher sensitivity to detect early primary latent syphilis. But the downside is that you may have potential over-treatment with false positive results because it's very sensitive, and of course the cost issue. Okay, but if you look at guidelines worldwide, every country actually are using reverse screening algorithm, and in fact in our recent 2024 Malaysian guidelines we are actually proposing to actually move towards using reverse screening algorithm. Okay, so a bit on treatment. So again, primary, secondary, early latent syphilis means it's early syphilis. So the treatment is just benzathine penicillin 2.4 mega unit stat dose would be adequate. For those who are allergic to penicillin, then you can consider using doxycycline for 14 days. All right. Now move on to case number 2. Case number 2, we have a 29-year-old MSM, regular ice use for chemsex. He's been diagnosed to have HIV via rapid test during a routine checkup. He's asymptomatic, and then his RPR turns out to be 1 in 32, and his TPHA was positive. And he denies any syphilis in the past. So we do see patients like this who has never been tested or never been treated for syphilis, and just coincidentally they do a medical checkup and it turns out to be RPR with a titer and TPP positive. So what is the diagnosis here? All right. So here is basically because patient is asymptomatic, hence is latent syphilis. Yeah. So latent means asymptomatic. So it can be divided into early latent and late latent. If you remember just now when I talk about classification or stages of syphilis, so early latent is the first 2 years of infection. That is, the infection has been acquired within the first 2 years, whereas late latent, the infection has been acquired beyond 2 years. It is less infectious, but it can still be transmitted, for example, from a pregnant mother to the baby. So in this case, this patient has a latent syphilis of unknown duration because the patient was never tested for syphilis before, has never had syphilis treatment before. So you don't know when the patient actually has acquired the syphilis, right? So in this situation, you should manage the patient as late latent syphilis, okay? Right. Then you have tertiary or late syphilis. Tertiary or late syphilis is something very rare that we see these days. It is non-contagious but highly destructive phase of syphilis, which may take many years to develop. So it's very disfiguring. But again, as I mentioned, it's not very common that we see these days because of the advances of, penicillin and whatnot. Okay. Then okay, so move back to our second case. Remember that his baseline RPR was 1 in 32 when he went for medical checkup. So because we have labeled him as latent syphilis of unknown duration, so he has received 3 doses of benzathine penicillin. At month 3, we repeat the RPR as part of monitoring. So it has actually come down from 1 in 32 to 1 in 16. So there is a 2-fold reduction, right? At month 6, it comes back up to 1 in 32 by 2-fold increase. And then at 1 year, it remains at 1 in 32. Okay, so you don't see the what you expect to have a 4-fold reduction here. So it remains at, it yo-yos from 1 in 32, 16, 32, and remains at 32. On further questioning, he claims that he has abstained from sex 1 month post-treatment. He has a regular male partner who has been treated as syphilis contact, and his partner's RPR was non-reactive. Both him and his RMP, his regular male partner, report no other partners, and he remains asymptomatic. So if you see this sort of patient, what is happening? Do you think that the patient is still reinfected, hence the titer has never really come down? Or are we dealing with treatment failure? All right. So when we want to label someone with treatment failure, they have to fulfill this criteria. Number 1, if the patient has symptoms to begin with or signs to begin with, the symptoms and signs persist, or they have resolved and then it reoccur. That's number 1. Number 2, there is a sustained or a 4-fold and greater increase in RPR titer. So in this patient, it was 1 in 32, 16, 32, 32. There is a sustained RPR titer. Okay. And point number 3, reinfection must be excluded. Okay. This is difficult. Okay. So sometimes a patient may say that, they are clearly no longer sexually active. Their partners have been treated and tested and whatnot. But again, we have to try and, it's up to your discretion to make this judgment whether the reinfection has been excluded or not. But basically, just want to say that if, okay, let's say the point number 2, when we monitor the RPR, if the RPR titer fails to reduce by 4-fold within 6 to 12 months, then it fits the criteria of treatment failure. The patient should undergo lumbar puncture to rule out neurosyphilis. And if you have ruled out neurosyphilis, then it is suggested to repeat another cycle of benzathine penicillin at weekly interval for 3 doses. Okay, So we give time for the RPR to come down up to about 12 months usually. There are some literature saying, for example, in HIV patients, it may take up to about 24 months for the RPR to finally go down. Yeah. So again, you need to look at the whole picture in terms of the patient remains asymptomatic, there is no reinfection, then most likely we are dealing with treatment failure. All right. Okay. So when do we decide to do lumbar puncture? Again, here I've sort of summarized on what various guidelines recommend and what our 2024 Malaysian guideline recommends. So here, if we follow the 2024 Malaysian guidelines or the 2015 BASH British guidelines, when to do LP is when the patient has symptoms, being it neurological, ocular, and auricular signs and symptoms, then you should subject the patient for lumbar puncture. Or if the patient meets the criteria of treatment failure, as I mentioned earlier. Okay. In 2020 IUSTI, which is the European guidelines, basically it suggests to do lumbar puncture if the patient has tertiary syphilis, or they have this special section to exclude asymptomatic neurosyphilis. Means that if the patient is living with HIV with a CD4 of less than 350 and the RPR titer is more than 1 in 32, according to the IUSTI guideline, they suggest to do LP. Okay. CDC is basically the same, whether the patient has got signs and symptoms of neurological involvement, and then treatment failure and all the other things. So, but here in Malaysia, we follow this. Generally, if they have signs and symptoms or if they meet the criteria of treatment failure. All right. What is the CSF criteria for neurosyphilis? So again, for our 2024 Malaysian SDI guidelines, we follow what BASH guideline recommends as well. We look at the CSF white cell count in a HIV negative patient if it's more than 5 microliter, or if the patient is HIV positive, we tend to take higher white cell count of more than 20, because in HIV positive without neurosyphilis, because of HIV itself, the white cell in CSF can also be raised more than 5. Okay. But if the patient is on effective antiretroviral, the viral load is undetectable with a CD4 of more than 200, we take the white cell count range between 6 to 20. All right. Then we look at other parameters on the CSF, either HIV or not being HIV. If the protein is generally more than 0.45, if your CSF VDRL is positive, or TPPA titer, which we don't routinely do, if it fits one of these, then you have to consider the diagnosis of neurosyphilis. All right. Okay. So the treatment here for late syphilis, whether late latent, gummatous, or cardiovascular, is to use benzathine penicillin 2.4 mega unit weekly for 3 weeks. Or if they're allergic to penicillin, then we can consider using doxycycline for 28 days. And for neurosyphilis, usually they will need to be admitted for a 2 weeks course of IV benzyl penicillin or C-pen in the ward. Okay. Right. Some additional management points when we manage syphilis. If the drug administration is interrupted for more than a day at any point during the treatment course, it is recommended that the entire course is restarted. Okay. The second point here, if you decide to treat the patient as late syphilis, means that they need 3 doses of benzathine penicillin in a weekly interval for 3 doses. If the patient defaults the treatment more than 10 to 14 days in between the weekly doses, meaning that the first dose and the second dose, there is an interval of about 2 weeks, or if the patient is pregnant and the interval between the first dose and the second dose, there is a delay of more than 9 days, then when the patient actually turn up, you need to count that point of time as day 1 again. Okay, you shouldn't continue. So this is what CDC actually recommend in terms of the management point of syphilis treatment. And then again, when you initiate penicillin injection, you need to warn for possible reactions to the treatment. particularly the Yarich-Herxheimer reaction, which is a self-limiting sort of phenomenon that can happen within the first 24 hours after you inject the benzathine penicillin. They can get fever, chills, rigors, nausea, vomiting, but usually it's self-limiting or symptomatic treatment, and usually within the first 24 hours. Then, of course, the risk of the possibility of anaphylaxis and allergy to penicillin. A bit on advice on contact tracing. Generally, for any STI, contact tracing is important because, as you know, if you treat the index case or the patient, if you don't address the sexual partners in terms of testing and treatment, then you know that the patient can be reinfected, and then it can also spread and cause public health issues. So patients who has been treated for syphilis should be advised to abstain from sexual intercourse until 1 week after the patient and their partners have completed treatment. All right. And all sexual partners should be examined, investigated, and treated epidemiologically. All right. So depending on which stage of syphilis that the patient comes, let's say, for example, if the patient comes with primary syphilis, so you need to look back for 3 months from the symptoms or the last negative test of the patient, and then you get the patient to contact trace the last 3 months, how many sexual partners that the patient has, and then advise them to actually come to a healthcare facility for testing and treatment. If he comes in with secondary syphilis, then the look back period is 6 months. Or if it's early latent or other stage of syphilis, we go up to about 12 months for contact tracing of the sexual partners. Here, basically, in the guidelines recommends that sexual contacts of less than 90 days before the diagnosis, the contact should be epidemiologically treated, means that they should receive IM benzathine penicillin 2.4 mega units step dose, even if the serologic test results of the sexual contacts are negative. So this is what we call epidemiological treatment. If the sexual contact is beyond 90 days, but the serologic tests are not immediately available, or the likelihood of the sexual contact to be lost to follow up, then you should also institute your epidemiological treatment on the same day. All right. So, but if the sexual contact serologic tests are positive, then the treatment should be based on the syphilis stage. All right. So this is my final slide. Some take-home message. Presence of signs and symptoms with risk factors for syphilis should be the first driving force to rule in or to rule out syphilis. And syphilis serology is useful to detect asymptomatic cases in key population, especially in MSM community and high-risk pregnant mothers. Think of proton phenomenon, especially in secondary syphilis, HIV, neurosyphilis, and in pregnancy. And always make an effort to ensure contact tracing is done and epidemiological treatment is given. And moving forward, I think we should all move towards using reverse screening algorithm rather than the conventional traditional screening algorithm. So these are my references. With that, I thank you.
So thanks very much, Kyril, for really that everything you wanted to know and didn't know, but now you know about syphilis. I think you've managed to speak for at least a whopping 40 minutes of highly comprehensive. So thank you once again. We've got a couple of questions in the question and answer chat bot. So I'll read some of the questions first and then maybe ask you a couple of questions myself. So the first question is this duration of cutoff for early and early latent syphilis and then latent syphilis. And some guidelines use 1 year, other guidelines use 2 years. So maybe you could just expand on this. In your slides, you use 2 years.
Yep. You are right. If you look at CDC guidelines, for example, they use 1 year kind of duration to divide early and late syphilis. But we sort of, when we did the revision of the STI guidelines, we decided to follow the the BASH guideline, the British guideline, where they actually use 2 years instead of 1 year. I can't remember offhand why we all decided to do 2 years instead of 1 year, but I think we followed back in 2015, the fourth edition of Malaysian STI guidelines as well. It was also written as 2 years. And we had consensus that I think we take it as 2 years as per what BASH recommends. Yeah.
Right, okay. Yeah, so I think majority of people use 2 years as well, if I'm not mistaken. The CDC is maybe an exception to that. So okay, so 2 years in the Malaysian guidelines. Okay, second question is a case, and it's been brought up. We have a middle-aged gentleman with an RPR of 1 in 32, but TPPA is negative. As usual, patients deny high-risk behavior activity. Patient is asymptomatic, no signs and symptoms of secondary or primary syphilis, no neurological symptoms, denies taking any medications, has had other tests, including an ANA, and the results are weighted, and they're repeating the syphilis results. They'd like to send other tests, including a CLIA in Sungai Buloh, but rejected. So what's your opinion regarding this case? And given the RPR titer, is it significant? And what would you do after that?
Right.
And what alternative tests is available that you would send?
Okay, so titer of 1 in 32 and TPP is negative. Patient denies high-risk behavior and asymptomatic. So the first question is asking whether so generally, I don't think there is a specific definition of cutoff when to say whether a certain titer is considered high or low or accepted or not accepted. Generally, if you read all the literatures and guidelines, they take anything which is more than 1 in 8 is considered high. So 1 in 32 is pretty high. But again, this is a non-treponemal testing, which is quite subjective, and in a sense that I've mentioned, is operator dependent, so it depends on who reads the RPR cut and to give you the titer. But it's reassuring to see that the TPPA is negative here, so it's a little bit less, I would say less likely to be syphilis rather than unlikely to be syphilis. But of course, if you still clinically suspicious of the patient has got syphilis, high risk activity and whatnot, I would recommend, it would be good if you can do a CLIA, or even if you can actually just continue to repeat his RPR and TPPA, probably about 2 to 4 weeks later, and see whether the TPPA turns out to be positive eventually. And the second question asking about KKM lab in Perak not doing other than, what are the alternative for non-treatment? So the other option is sometimes if you can actually get the patient to go to private and do a CLIA or an EIA testing, but of course patient has to pay. But I think in Malaysia, I think not many centers are actually starting doing reverse screening. So I think in Perak, they are still using traditional testing. So that's another option. Either you repeat another RPR or TPPA about, let's say, 4 weeks later, or you can actually advise the patient to go to a private lab to actually do an EIA if it's available. Yeah.
And so if you repeat the test and a specific treponemal test, whether it's CLIA or something else, in let's say 4 weeks or so, and it's still negative, would you then conclude that the patient has the test is a false positive?
Then again, if you really, the patient has no high risk activity at all and remains asymptomatic, then I would just call it a day and say most probably it's false positive.
Okay. Great. Yes. Okay. Thanks very much. We've got a couple of minutes, so I'm going to just go through the questions. About maybe you could comment on the VDRL availability in private labs or private hospitals. Currently, a VDRL test is not available in any private lab or private hospitals, and it's only available in Hospital Sungai Buloh. I don't think that's true. It's only offered to test on CSF for neurosyphilis. So maybe that's a comment, and if you want to comment on that, please.
Well, I mean, again, VDRL versus RPR, they are basically same thing because it belongs to the non-treponema testing. Of course, I think there are slight differences between VDRL and RPR. If I'm not mistaken, I think RPR has got slightly higher sensitivity than VDRL, if I'm not mistaken. But again, it doesn't really matter whether you have RPR or VDRL because both are still considered as a non-specific treponemal testing. So now I think we are moving away from VDRL. I'm not sure why, but RPR is available. But of course, when we want to test for neurosyphilis, when we send a CSF, we don't have a CSF RPR. We only do CSF VDRL. And in the guidelines also mention that there is only data available looking at CSF VDRL positivity to determine whether it could be neurosyphilis or not. So don't worry if you don't have VDRL, as long as you have RPR, it's equivalent, because both are non-treponemal testing.
Great. Okay. Another two questions, if that's okay, Kariel. Pregnant lady, so it's a case, rhesus negative, but Coombs test positive. She's not high risk. Her rapid test is positive and a TPPA is negative. Autoimmune panel also negative. Do you think that a rhesus negative mother who has a positive Coombs test can cause a positive RDT?
Okay, that's tough. So rhesus negative Coombs test positive, but not high risk. So when you do an RDT and a TPPA is negative, I wonder whether when you do the RDT, you should proceed with RPR and see whether the RPR gives you a titer or not. But looking here that if the RDT positive and TPPA, let's say the RDT is positive and the RPR titer is also non-reactive and the TPPA is negative, then most likely the RDT is a false positive. Okay. Generally, RDT is a treponemal specific testing, so it shouldn't be prone to getting false positivity. So I have not come across and I'm not aware that if it's rhesus negative mother may cause this, but it shouldn't theoretically because we know that treponemal specific testing like RDT should not be prone to be getting false positivity. So it's either because of the RDT kit itself or the way how it's done or, or how we interpret it. So it is all, because we do get FMSs calling and asking because the RDT is positive, but no risk factor, RPR non-reactive, TPP negative. So sometimes it's the kit itself. So it depends on whether it's been properly validated or which kit has been used. Right?
Okay. I think we'll take one final question from the Q&A session. That's the last case, which is, does the RPR titer correspond to the stage of the disease? For example, if the patient's a 60-year-old with underlying end-stage renal disease, on regular hemodialysis was found to be positive with an RPR titer of 1 in 8 and TPHA was detected. Patient is asymptomatic. Patient's never been treated for syphilis before, and should they treat this patient as early or late latent syphilis with such a low titer?
Okay. Generally, late disease tends to have lower RPR titer as compared to early disease. So if you remember early syphilis, you either have primary, secondary, or early latent. They tend to have higher RPR titer because they tend to be more infectious in the early phase, as opposed to late disease. If they come in with late latent of unknown duration, we expect the titer to be lower. So that's how but it's not always true all the time. So in this situation, you have a 60-year-old end-stage renal disease, RPR titer 1 in 8 TPHA was detected and asymptomatic. So this patient, I assume, has never been treated for syphilis before. So it should be treated as late latent syphilis because patient has never had history of syphilis in the past and the titer is 1 in 8. some people think it's low, but there is still a titer, but the TPHA was detected. So it means that he has a serological evidence of syphilis. So means that this patient should be latent syphilis of unknown duration. So I would actually institute benzathine penicillin weekly for 3 doses for this gentleman.
And also to add, if I may, that since the reverse algorithm was started, I think we're also encountering a lot of these cases where not necessarily the RPR is low, but you have an RPR negative test and a positive TPPA. And, in circumstances where we wouldn't know this before, a lot of people didn't know what to do with them initially. But as you say, we're treating them as latent syphilis. Now, I'm just going to use my position as chair to maybe extend this by a couple of minutes, if that's okay with everyone, maybe by about 3 minutes, because there are 2 other questions just came in. And I think one is from my colleague in UMMC. So I think I'll take that. I think if you could take that question. Great talk, Dr. Khairil. Any advice for HIV positive patients with ocular retinitis, where both CMV and syphilis serology are positive? Retinitis can appear similar in both cases. Which should be treated first, syphilis or CMV?
Right. So ocular retinitis, CMV and syphilis serology. So CMV serology, I assume it's serology. So it's not CMV PCR, it's not CMV viremia. So if I'm not mistaken, syphilitic, ocular syphilis tends to be of uveitis. It causes more uveitis. I'm sure it can also cause retinitis. But sometimes what we do, we have a chat with the ophthalmologist and see what is the likely, because they will probably be the best person to advise you whether, this probably more resembling or CMV retinitis as opposed to syphilitic ocular involvement. But in this situation, I guess if you only have a CMV serology positive, not a CMV PCR viremia, then I would probably treat the syphilis first, and then probably have a chat further with the ophthalmologist and see whether, send off CMV PCR to look, and then wait, and then maybe later to treat the CMV, rather than, or if it's a life sort of if it's a life-threatening condition where you need to treat both, then I think there's no harm to treat both as well. But again, it's good to have a discussion with the ophthalmologist, and they will be able, the best person to actually advise you whether this is more a CMV changes or a syphilitic changes, I think.
Final question.
Anything to add on to that?
Yeah, I think CMV is a clinical diagnosis, and I think you can't rely so much on CMV serology. So if it's a clinical diagnosis, it's going to be, I would definitely speak to the ophthalmologist first. And as you say, it causes more often a retinitis, whereas syphilis, the great mimicker, can cause anything, right? Including a retinitis, but less commonly a retinitis, either a uveitis or either an anterior, posterior, or panuveitis. My final question to you, Khairil, this treatment of serological failure in the context of syphilis can sometimes cause a lot of headaches to all of us, because we ask about the possibility of reinfection, and often there's a social desirability answer. So patients answer in response to what you want, they an answer to what they expect, or what you want to hear from them. And often when you ask questions like, is there a possibility of you having had sex because your titers have gone up? And most of the time it's caused by you having had sex with somebody who has had syphilis. But you're in this clinical context where patients think it's best not to say no, right? And so they don't volunteer this history of reinfection, and they end up getting treated again because they have not documented their history of reinfection. So, this is just a general question. How do you sort of improve maybe communications with patients with underlying syphilis, so that this history of reinfection is more accepted, I guess, in a way, so that most patients don't end up having lumbar punctures, because patients are too afraid to tell the doctor that they've been re-exposed again, if you know what I mean.
Yeah, that's a very good question. So again, sometimes sometimes what I do with my patients, if the RPR remains persistently high and they deny of having the risk of reinfection, so I would try not to sort of give negative comments, in a sense, like trying to be judgmental and say, look, or ask directly, like, oh, you are still sexually active. So we don't want, so it's just, I will usually just say that, oh, I'm a bit concerned and worried that your titer is still high. Do you think, I will try and ask them whether to volunteer and say, is there anything that I should know? Or, rather than just say, oh, your titer is still high, I'm sure you are still having unsafe sex, that sort of thing. So rather than just jump into conclusion that, but I will try to give the opportunity for them to be more sort of honest and explain. And secondly, sometimes what I would do is that, because the other thing is that sometimes we often forget addressing in terms of oral sex. Yeah. Because sometimes when we talk about sex, people always think about penetrative sex. So we do know that sometimes, via oral sex as well, that, syphilis, you can get reinfected as well. And then, I mean, how many people are actually, using condom for oral sex? So it's the other thing that sometimes we have to be more explicit when you ask about the sexual activity in terms of reinfection. But sometimes, yeah, I mean, it's quite difficult, I would say. It's more of how is your rapport with that patient. Or sometimes I would probably just give them time. If they don't want to come up with, I would probably just see them again, the next appointment, and give some time and see whether they can actually will open up eventually. Yeah. But again, Prof, you know that trying to convince someone to actually do LP is very difficult here in our country, isn't it? So sometimes we just let it be, and we'll just play by ear and see how it goes. Yeah.
Absolutely. Thanks, Kari. Dr. Vidya, I apologize if we went over time. You can scold me later on. I'd like to thank Dr. Kyril. He's been for his very, very comprehensive session on everything you need to know about syphilis, from diagnosis to management, and the interesting case scenarios that he presented. So I think with that, I will let Dr. Vidya say last words, and Dr. Kyril before we close the session.
Yeah, okay. Thank you, Prof. Raja. Thank you very much, Dr. Kyril, for that excellent talk. And thanks to the participants as well for being very interactive this time. I think there are a few unanswered questions, and there's also some in the chat box, which is not in the Q&A. Probably, Dr. Kyril, if you don't mind, you can reply to them there. Because I think there's one quite important question as well. Dr. Kyril, do you mind taking one last question?
Which question is that, Vidya?
It's
in
in the chat. In the chat. It's not in the Q&A. The one from Hafizi.
Oh, it's in the chat.
Yeah.
Hafizi. Okay.
And I think, yeah, Prof. Esha also has actually mentioned that part where she said that is SLE. I think it's with regards to the question about the pregnant mother with the Coombs positive. Because Prof. Esha is a rheumatologist, so I think she answered that in the chat box. I'm not sure if people realized it.
All right. Okay.
Yeah. So we just take one last question, if you don't mind.
So the question is, how do you differentiate between serofast and treatment failure? Okay, that's also a good question, because as you all know, serofast basically means that the RPR titer does not come to non-reactive despite of adequate treatment. So it will always have a specific sort of certain number lingering there when you monitor, either being 1 in 8, 1 in 16 and whatnot. So generally, again, if you look at literatures or guidelines saying that serofast, anything more than 1 in serofast shouldn't be a very high titer. Generally, it's about 1 in 8 and below, but sometimes we do see serofast of higher than 1 in 8. So it's quite difficult sometimes, but what I would do is that if the patient has been persistently at that titer, let's say 1 in 8 or 1 in 16 for the next 1 year, you'll be monitoring and patient remains asymptomatic, and and there's no risk of reinfection and whatnot, then I would just leave it as it is rather than to label as treatment failure. But of course, in any time when you monitor and you see there is a sudden fourfold increase from that baseline serofast titer, then it's a different story. So again, you know, it's something that you just have to try to bite the bullet and see and just continue to monitor, because there is no sort of a concrete sort of specific criteria to say that, look, this is serofast. Okay, but generally we know that as long if the patient remains asymptomatic and the titer, 1 in 16, 1 in 8, that's fine. Then it's probably just serofast, and it's persistently, persistently throughout the whole, let's say 1 year has been same, then I guess it's okay.
Okay. Okay, sure. Thank you so much, Dr. Khairil, and Prof. Raja, for your time. And thanks to the participants as well for joining this week's session. So join us next month for topics on nephrology. Okay, take care, everyone, and have a good day.
They're going to be very sad because it's the end of the infectious disease month. Okay, I can guarantee you that. Okay, take care.
Okay.
Bye-bye.